Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend this time with us. And today we have a very timely topic that's going to be brought to us by Dr. Stephen McLeod Bryant. Without further ado, I'm going to turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. How are you? Can you hear me well?
Yes.
Yes.
Good. I want to introduce Dr. Stephen McLeod Bryant. He's a new person to me. We talked earlier today. He's the immediate past president of the Black Psychiatrists Association of America, and he received his BA and MD degree at the University of Rochester and completed his residency in psychiatry at the Tufts New England Medical Center in 1988. He has served on the faculty of the Department of Psychiatry and Behavioral Science at the Medical University of South Carolina, during which he also served 2 years as medical director of the South Carolina Department of Mental Health. And we're looking very forward to hearing from this gentleman. He has also been a Life Fellow of the American Psychiatric Association, the APA, the president of the South Carolina Psychiatric Association, and served as the American Psychiatric Association Caucus of Black Psychiatrists, and represented of the APA's assembly from 2003 to 2016. He recently completed his term, as I mentioned before, as president of the Black Psychiatrists of America. He's also the immediate past president and is the recipient of the American Psychiatric Association Solomon Carter Fuller Award and a member of the American College of Psychiatrists. And I understand he's also a member of the great fraternity Alpha Phi Alpha. Dr. McLeod, please give your presentation. Welcome to the Black Health Trust. And our audience is mostly lay people. We have a few physicians with us. Thank you so much for joining us.
Thank you, Dr. Maxey. A-Phi.
A-Phi.
So this talk that I'm about to present, I just gave in Grenada at our transcultural conference, the Black Psychiatrists of America. It was inspired, if you will, by current events that have been very hostile towards focusing attention on the plights of Black folk, particularly Black folk with mental health conditions in our country. And so the title of my talk is, may I say, quote, disparity, unquote. If the slides could be shared at this time, I'll be speaking from them. Or do I have to share that?
How do you want me to handle it, Simon?
You can go ahead and share your screen.
Okay. So as I said, may I say disparity? Again, out of the context of efforts by the government and political forces to scrub the notion of diversity and equity and inclusion from the rubric of scientific inquiry as it comes to disparities. I thought it was high time to discuss whether I can, whether we can, and how we can continue to focus on the disparities affecting our community. No financial disclosures of conflict of interest in presenting this material. My talk, which it will run about 30 to 40 minutes, has three basic objectives. I'm going to enumerate the current political forces affecting the study of and elimination of racial and ethnic disparities. I'm going to review how social determinants drive mental health disparities, and then identify how imbalances in social determinants can be reduced to eliminate mental health disparities despite the current political climate. So I began my talk before a live audience by asking a couple of questions just to get a sense as to whether I was preaching to the choir or not. The first question was, just in general knowledge, in aggregate, do Black Americans with DSM-5 or psychiatric disorders, when compared to white Americans with such disorders, do they have significantly worse, the same, or better mental health outcomes when comparisons are made? And as I'm sure everyone here in this audience is aware, Black Americans typically have significantly worse mental health outcomes when compared to white Americans with many of the psychiatric disorders that I and my fellow psychiatrists commonly treat. There was a second question that I asked, though, which is a little more nuanced, but that given current presidential executive orders, National Institute of Health, and SAMHSA directives, which are trying to scrub DEI from scientific efforts, I asked the question as to whether such orders and directives, though it may make it difficult to allow research and interventions, which would reduce racial and ethnic disparities, could such research be conducted despite the difficulties, and in fact improve disparities? Or would the current disparities just remain the same, given the lack of attention to those efforts by the federal government? Or would this actually worsen racial and ethnic disparities? And as you can imagine, there's some disagreement about what the full impact is. In general, most folks don't think it's going to help any, but there are those of us who believe that still some progress can be made, and that's what I want to focus on during the rest of my discussion. So first, just in enumerating the current political and social climate that we face. You'll recall early on in President Trump's presidency, he signed the Executive Order 14173, so-called Ending Illegal Discrimination and Restoring Merit-Based Opportunity. And in this particular order, just taking out a couple of passages from that order, he stated that roughly 60 years after the passage of the Civil Rights Act of 1964, critical and influential institutions of American society, including the federal government, major corporations, financial institutions, the medical industry, emphasis mine, and institutions of higher education, have adopted and actively used dangerous, demeaning, and immoral race and sex-based preferences under the guise of so-called, quote unquote, the new four-letter word DEI, and that these efforts can violate the civil rights laws of this nation. He further went on to state that he therefore ordered all executive departments and agencies to terminate all discriminatory and illegal preferences, mandates, policies, programs, activities, guidance, regulations, enforcement actions, consent orders, and requirements. Several months later, the Director of Health and Human Services, Robert F. Kennedy Jr., and his agency, SAMHSA, announced their new strategic priorities, which included this statement that SAMHSA had previously invested substantially in ideologically laden concepts like behavior health equity and focus on health disparities. SAMHSA will prioritize efforts that go beyond addressing health disparities to focusing on solution-oriented approaches. Within this document, the summary, this executive summary of the new strategic priorities, SAMHSA indicated that though much money and attention had been placed on racial and ethnic disparities in healthcare, that relatively little had been gained from this process. And in keeping with President Trump's assertion of this being un-American and illegal, SAMHSA would no longer be focused on addressing these issues. But these efforts are not only on a federal level. You'll find that there are nonprofit organizations that also are pursuing this agenda and assisting the federal government in their process of scrubbing DEI from healthcare initiatives. There's a nonprofit organization, Do No Harm, which was started by a physician, Dr. Stuart Goldfarb, which has as its mantra, protecting healthcare from the disastrous consequences of identity politics. Every day, if you go to their website, they have a news feed in which they highlight their efforts to point out initiatives that are race-based or gender-based, and which they will point out as being harmful to the safety of Americans because of their lack of attention to true quality and more providing favors to so-called disenfranchised people. And this is just one example from Duquesne University School of Osteopathy. And Duquesne had announced that they were sort of changing the focus of their DEI initiatives, and Do No Harm is calling them to task for they shouldn't just rebrand its DEI programs with more benign terminology. They should make it unequivocally clear that it rejects this divisive, dangerous ideology. They also had attacked the University of Pennsylvania's efforts to provide a directory of Black physicians for their community that had been, they were responding to requests from the community to make a resource available for those individuals who wish to seek out a Black physician as opposed to a physician of a different race or ethnicity. And Do No Harm threatened to file suit with regards to this particular initiative. So, given the hostility that is currently present in, the federal government and in terms of some of the activities of nonprofits out there looking for organizations or people or researchers trying to maintain focus in this area, it raises a question: can we even discuss this very reality that we know is out there in our communities? And before going further to sort of describe my perspective on whether we can say disparity or not, I wish to point out the words of a mentor of mine, Dr. Ezra Griffith, who is a psychiatrist, forensic psychiatrist renowned at Yale University, who did a wonderful biography of Dr. Chester Pierce, one of the founders of the Black Psychiatrists of America. And in that biography, he noted the fact that when reviewing and considering criticism of the words that he put to paper regarding Dr. Pierce, that it's important to remember that there's no way of correcting perfectly the lens through which an individual autobiographer sees the world, or the hearing aid through which the storyteller first hears the facts. And I'm going to be talking about the facts of disparity within the Black community when it comes to mental health. But it's important to keep in mind that, and I try to keep this in mind when communicating this to various audiences, that I have my own particular lens based on my history. As Dr. Maxey mentioned, I was educated at the University of Rochester, undergrad and medical school. I was raised in a predominantly white, rural, upstate New York community, through which my experience of racism and my experience of opportunity significantly shapes the way I view current circumstances and how I read the literature and the facts through which I'm presented with. And so I want to keep that in mind. And as we discuss what I have to say and have, further discussion after the presentation, I think we all have to remember what filters we bring to this particular equation when we're trying to communicate our feelings, our realities to others who may not feel similarly. So first, in terms of just as a review, it's important to remember that this notion of disparity is something that's not a static concept. It's not that when we look at a particular difference in outcomes, whether it's mental health or physical health, that this is born of a lifetime cycle of experiences, even before birth, the disparities in nutrition, disparities in terms of this maternal safety, maternal environment begins a track in which differences in mental health outcomes becomes a reality. Initially, when presented with the data of these differences in outcomes, a lot of attention was placed on the individual interaction between the medical care clinicians and the individual patients. And so there was a lot of focus on bias, clinician bias, discrimination, and that sort of thing. But as more and more research over the years has gone on, we realize that there are other important factors that play a role on this interaction between clinician and patient. And in fact, these larger economic and social opportunities and resources, living and working conditions in homes and communities, that in a sense, regardless of whatever specific bias that clinicians may bring to the individual clinical encounter, that these larger social determinants of health play a much bigger role in terms of the outcomes that we are seeing with regards to mental and physical health. For instance, when we look at the difference in life expectancy that was seen between non-Hispanic blacks and white males over time, in the 1970s, it was an 8 years difference, as you can see. As attention and focus brought by Surgeon Generals such as Jocelyn Elder, Daniel Satcher, and the National Academy of Science and other agencies began to point to this disparity that shouldn't be there. More and more attention was paid to how to bridge those gaps and make our outcomes more equalized. And you see over the decades, as more and more attention was paid to this, that there was a shrinking of the gap from over the 40 years from 1970 to 2010, from 8 years to 5 years. And unlike what the SAMHSA executive summary would suggest, a lot of the progress was based on the research looking at the social determinants that were going into the differences in life expectancy and looking at ways to improve access, to improve the education of the community so that changes in behavior as well as changes in medical practice could occur to begin to bridge the gaps in terms of life expectancy. Of course, as we all know, come to 2020, there was a loss of some of the progress made in the COVID years, highlighting again the importance of social determinants in leading to inequitable outcomes. But again, I just want to underline the fact that there is data to show that improvements in reducing disparities are there, have been there, unlike what the administration would lead us to believe. One of the most important aspects of this science of social determinism is the fact that we can quantify the vulnerability imposed by social determinants into a measure that actually, by zip code, we can identify those zip codes that if you live within that zip code, you're either at more or less risk of developing a whole host of medical and psychiatric vulnerabilities. The so-called social vulnerability metric was developed. It was published in 2023. It was composed of available governmental databases, which are probably at risk at this time just because of the government's lack of respect for real data. When you fire the statistics director of the Bureau of Labor Statistics because you don't like the numbers, that calls into question how reliable all these public databases will be in the coming years. However, up until this time, 2023, the Agency for Healthcare Research and Quality had 17 public databases that tabulated various measures at the level of zip code. And Salisbury and their group looked at these public databases and came up with a measure that spanned 5 domains: demographic, education, economic context, physical infrastructure, and healthcare, and found 24 relatively independent measures over those 5 domains that could be used as a measure of a zip code's social vulnerability. And the use of that measure is demonstrated in the following study, which was published earlier this year in the American Journal of Psychiatry. This study is looking at the prevalence of schizophrenia spectrum disorders in the Black, multiracial, and white communities. It was based on a national survey in which folks were statistically identified randomly. They were then interviewed in terms of their current and past symptoms, and putative diagnoses were made: schizophrenia, schizoaffective disorder, delusional disorder, or the presence of any sort of psychotic symptoms that didn't meet diagnostic criteria. And what this study showed was that the yellow was just the straight out prevalence in the various communities um, uh, that Black folks that had been interviewed were roughly 3 to 4 times more likely to present psychotic symptoms than their non-Hispanic white counterparts. However, if you factored in the social vulnerability metric, those Blacks who were in vulnerable zip codes were much more likely to experience these symptoms than those who were not. So that if factoring in the social vulnerability metric reduced the prevalence of psychotic symptoms almost in half when compared to their white counterparts. I leave it for further discussion that the fact that multiracial, non-Hispanic, multiracial individuals in these communities in the sample had significantly higher rates than their Black or white counterparts, which may say something about the stress, the vulnerability of folks who identify themselves as multiracial in the present American society. So what can we do given the current political climate, given the reality that there are still disparities that are out there that are that with the will and the knowledge and the energy that we can reduce if given the opportunity. So I share a photo of a colleague who I've worked with before in the American Psychiatric Association. She's been a big support within the Black Psychiatrists of America, Dr. Annelle Prim from Baltimore, who back at the turn of the century, 2001, did an effort to produce a video for the African American community called Black and Blue: Depression in the African American Community. One of the areas that's been found contributing to disparities with regards to mental health outcomes in the Black community, of course, is stigma and lack of education about the nature of mental health disorders and the treatments that can be beneficial in lowering symptomatology. And so she did a video featuring African American men and women, spectrum of the ages, talking about what depression was like for them and treatments that helped them to feel better. And now with Earlier before we got started, we were joking about technology and how our young people have to help us out. I've been very enthused by the younger cohort within the Black Psychiatrists of America who are using podcasts and social media to get the word out to various communities in novel and important ways about what mental health care is all about and how we can do better as a people in maintaining our mental health. Another way in which we can have an impact is by creating culturally competent and culturally aware ways of providing the services that we know are effective and evidence-based. Another active member of the Black Psychiatrists of America, Dr. Iana Jordan, when she was a faculty member at Yale University, developed a so-called Imani Breakthrough Project for helping people with substance use disorders overcome their substance use and recover. And the novel thing about her breakthrough project was that she developed a coalition with faith-based houses of worship, as well as with the recovery community itself, to provide the actual clinical support. She developed a program that focused not only on abstaining from substances, but also on addressing the areas of inequity that were occurring for many of the folks involved in this process. She was targeting Black and brown people who were having substance use disorders, and she helped them in their recovery to become more actively engaged in civil society, addressing financial literacy, looking at justice issues, helping them be able to expunge their records if possible, or to scrub their records so that they could become employed. Looking at the totality of individuals in the society who are experiencing the negative consequences of being in socially vulnerable environments. She's now at NYU Langone Center, continuing to do this good work. Another way in which we can address disparities is by empowering the lay community. For example, the Confess Project of America is an example in which frontline workers in the beauty industry, barbers and grooming professionals, were educated in terms of how to talk about mental health issues, how to link the people that they were serving, their clients, linking them to resources if need be to help them maintain their mental health or overcome mental health issues. As it notes there, their particular curriculum was evaluated by Harvard University and has come to impact people all across the United States. Finally, I think what we can do is, as each of us, wherever we are at, whether we're on a faculty or whether we're providers in the community or acting as advocates for mental health care in our churches and our schools, we can always begin by meeting our audience where they are when we want to speak about the importance of addressing disparities. Before going out there and speaking our truths, I think it's important to know who it is that you're speaking to. Whether you are preaching to the choir, which makes it therefore easier to get to the point as to what we can do together to address the disparities, versus dealing with a hostile or skeptical audience. And that's why I asked the poll questions at the beginning. Whenever I'm giving this talk, I gave this talk earlier at the Medical University of South Carolina, who invited me to come back to do a grand rounds. I asked those questions to the audience and just ask for a show of hands. I wanted to get a sense as to, how much work did I need to do to bring people to a certain level of understanding about the reality of the disparities I was speaking about. Second, I think it's important that once we've identified where the audience is and we're communicating about the problem, I think it's important to underline the fact that this is not just a Black issue or brown issue or a people of color issue. This is a we issue. Disparities affect all of us. The fact that there is a poor outcome for Blacks in a particular mental health arena is indicative of a larger problem affecting all. And I'll give an example. Um, this is an old example. This is one of the first slides that I ever tried to make when this is back in 1988. And technology was not what it was. I didn't have a spell checker. I didn't have a lot. The slide is crooked. It was all, but it highlights one of the first studies that got me interested in this whole area of clinician bias and disparity. This is from 1988. Was published in the Journal of Health and Social Research, I believe. Loring and Powell were the authors in Indiana. And at this time, the American Psychiatric Association had just published the landmark DSM-3, or Diagnostic Statistical Manual 3, which was a significant sea change in the way we psychiatrists were diagnosing mental health disorders, as opposed to just sort of having some general consensus about what psychosis was, or neurosis, or depression. This statistical manual brought together experts from all over psychiatry to come up with specific criteria that had to be met, and not to have and to exclude certain features to be sure that our diagnoses were reliable and valid, and that we could do scientific research based on the diagnoses that we were making. And so we were patting ourselves on the back, and Loring and Powell were a little skeptical of how well we would do with this particular manual. And so they sent out two written case vignettes of people with schizophrenia from the emergency room at Indiana University Hospital. And in these vignettes, they basically were describing disheveled, disorganized individuals. They did not mention any sort of hallucinations or delusions. They were what was then called undifferentiated patients of schizophrenia. And they sent these vignettes to all the psychiatrists in Indiana, and they identified them as being either white male at the top, black male, white female, black female, or they weren't identified at all, the NI, non-identified. And they asked the psychiatrist to basically answer the multiple choice questions. They gave them a certain number of choices of diagnoses and asked them to come up with what they thought were the diagnoses. Now, if you go down to the last row, the non-identified row, you'll see that the psychiatrists passed. That 65% of the time they identified the vignettes as having schizophrenia, which given that this was actually an open book test, they could have gone to the DSM-3 and reviewed it. There was no prohibition against that. I guess that's okay, but it makes me wonder. Anyhow, you notice that in the second row, that when the cases just changed the wording and identified them as black males, the psychiatrists were great at, they did even better than when they weren't identified, at assuming that they were having schizophrenia. Not only that they were having schizophrenia, they were significantly more likely to choose paranoid schizophrenia as a diagnosis. Now, in order to make that diagnosis, the patient needs to be expressing delusions and or hallucinations. And these vignettes did not describe any hallucinations or delusions. And as many of you may know, this has been a major issue within psychiatry, the overdiagnosis of paranoid schizophrenia, and particularly in Black males, which has led to all sorts of disparities in terms of treatment and involuntary admissions and so forth. But again, my point is that this is something that affects all of us. It's not just a Black problem. Just below, you notice what happens when the vignettes, same wording of clinical symptoms, but they change the identification from Black to white, male to female. The rate of diagnosis of schizophrenia drops more than half. And in fact, they're much more likely to be seen as having a brief reactive psychosis, BRP, or a psychotic depression, which leads to all different sorts of treatments. For example, with the psychotic depression, much more likely to get an antidepressant in addition to an antipsychotic, whereas if they were just diagnosed with schizophrenia, they wouldn't get any antidepressant. So basically, the white females are being misdiagnosed, being mistreated in a sense, leading to disparities in an opposite sort of direction. So whatever issue is working here, whatever is causing this bias to diagnose one way or the other, it's affecting everyone who's involved in the process. And then finally, I think it's important that whenever we have the opportunity to talk about this, is that we come to this issue knowing, at least in my estimation, knowing that we can eliminate this disparity if we are given the resources, the will to do so, and given building on what we know from the research, we can eliminate these disparities. Now, these suggestions were actually on the CDC's website up until recently. I saw it as recently as 2024, the fall of 2024, but this has been scrubbed. There was an effort, how do we talk about eliminating disparities? It was web pages that were part of the CDC. That's been taken down. But it doesn't take away from the fact that this is an appropriate way for us to address these issues. So in conclusion, social determinants drive racial and ethnic mental health disparities, whether they're federally recognized or not. They're a reality, and though the federal government may want us to ignore them or believe they don't exist, that doesn't take them away. Imbalances in social determinants can be reduced to eliminate racial and ethnic mental health disparities, and eliminating imbalances in social determinants and thereby mental health disparities will improve the mental health of all. Thank you. I have a bunch of references. If I have sent the deck to Dr. Maxey so that if anyone is interested, they can get them from Dr. Maxey. So
Thank you so much, Dr. McLeod. This was outstanding. Outstanding. I learned so much, and I have so many controversial questions to ask you. And I have to say that two of the people that you talked about at first were two of my very best and most influential friends. The first one was Chester Pierce, who I met as a senior medical student intern who became one of my best friends. And the other one was Benny Prim, who's the father of Raquel Prim.
Right.
My first job when I finished my medical school. So those are two very close friends of mine. We talked about Welsing before that. But here's my sort of twisted question.
Okay.
Recently, looking at what many people follow in Christianity, in particular the evangelicals, there seems to be an event that they speak about from Genesis, and it's called the curse of Ham. And they denigrate so-called descendants of Ham. and saying that if you're not a son of Jacob, you're not really in God's will. And this goes forward to the so-called seven mountain concept that the evangelicals have, and also part of Project 25. Can you discuss how some of these teachings that many of us as Christians innocently look at can affect our social determinants of health and how we're seen by the master, I hate to say this, by masters in the United States of America?
That's an
I just,
excellent question. And uh, it makes me think of so many sort of different ways to respond. But ultimately, as a psychiatrist, what I'm very much focused on what people believe and
Mhm.
how people interpret what they see as facts. And so you're touching at one of the central pieces of um, what can be controlling and can be, um, um, in a sense, one of the causes of disparities. For example, in looking at um, the education and stigma of mental health concerns in the Black community, a lot of that stigma is driven by um, you know uh, religious belief, in the sense that many people have believed that you become depressed because of you're just not right with God, or the devil is got control of you and so forth. And a lot of those beliefs are have been promulgated from a certain evangelical perspective. So that's sort of one aspect of it, the stigma. Another aspect is something that I heard recently, in which I can't remember the preacher's name. I heard it on a podcast, but he talked about that Africans were introduced to God by the white man as part of an enslavement theology. But we introduced the Creator to the New World, and that we have a much richer tradition, spiritual tradition, that we have. That got sort of in many ways got beaten out of us, or that we forgot, that we tried to hide, and that we need to recapture that spiritual tradition to regain, our mental health. And so, yeah, your point is well taken, and I think that we need to examine what it is that we worship, the images that we worship, um, you know, who we're listening to, what, how the passages may be taken out of context or in context to suggest a particular way of shaping reality that's not true to us.
No, thank you so much. Dr. Barbara Neighbor Stevens? Dr. Neighbor Stevens? Is she
That
muted?
helps. Um, Thank you so much for giving us this talk this afternoon. It's extremely rich and one which requires some time to digest, I might suggest. One of the one of the thoughts I had as you were talking um, was linked to something that I saw this morning on one of the Sunday morning shows, where they interviewed several Black individuals who were homeless. And they made the point that it disproportionately, not surprisingly, impacts our community. And I mean, all of the conversations were extreme. If you were a sensitive person, would tear you up. But
Mm,
one in particular that struck me was that this couple who has been homeless for several years, and at one point the wife said, um, we did everything we were supposed to do. And the interviewer said, what do you mean? You, you're educated? She said, that's right. The two of us did everything that we were supposed to do. And despite all of our efforts, we find ourselves in this situation. And I was thinking, how many people find themselves in that situation now? And how can how can they survive the the pressure that this puts them under? And this couple had children as well. Um, you just alluded to going back and recapturing the richness of our religious um, ethos. And I definitely don't dismiss that. But I kind of feel that we need to think about more things than that,
Oh,
both
and
as the community and as those who may be in a position to help.
most definitely. Yeah, I don't want to leave the impression that that's all it takes. But one of the things that I always um, try to remember is the fact that we as a people have survived the Middle Passage. We as a people have survived slavery. We as a people have survived Jim Crow, lynchings, and as you know, as Isabel Wilkerson has described in her book Caste, we are living in a system that is totally consciously or unconsciously attempting to break us down, to keep us inferior, to destroy us, and yet we continue to rise. And I think it's important that the notion of, our ancestors, the folks um, who have survived and to thrive and to keep these stories alive, the Chester Pierces, the Benny Prims, the Francis Cress Welsings. These important figures are important for us to keep in mind and to remember, and to celebrate as examples of what it takes to fight these efforts to bring us down. One of the things that I'm doing as part of my post-academic career is I spend 2 mornings a week. In fact, yesterday I was at the Miami Street Medicine. I practice providing psychiatric care to homeless and uninsured people. The majority of them are African American here in Miami, and just providing whatever resources we can through our limited sample medications, and just being there and watching the growth of individuals who have had basically no hope, but knowing that somebody cares, somebody's going to be there to share their frustrations, to try to help them make a better way, despite everything that they've encountered through the years. I think just helping us remember our strength through our presence is a way to combat these forces that are trying to bring us down.
Thank you. Is Dr. Lawson on the Neighbor Simmons?
He is.
Yeah, I'm still here. Just
Hello,
want
Dr.
I just want to again emphasize. Stephen just brought up a number of themes that, in and of themselves, can especially be programs by themselves. He presented an issue that's been debated and discussed over the last couple of decades, and in a few succinct words. And I just want to thank him for doing a great presentation in terms of the discussion of these issues. just very quickly, I just want to note that my wife constantly reminds me there's a very active group in the Catholic Church, and which is dealing with the fact that there's about 1,000 different Black Madonnas, and that the idea that somehow white people brought Christianity to Black people is just false. And also, there's a lot of evidence now that that the Jews, the contact with African people, helped formulate their religion, and also my colleague, past colleague, Francis Walton, frequently emphasizes. Now there's plenty of evidence to support that person recalled that the Romans took a Black man called Jesus and converted him to a white man called Christ. So there's a lot of discussion about that. I think it's well worth discussing. Also, he emphasized the whole issue of misdiagnosis, ongoing issue. Dr. Carl Bell, and among others, have written about this extensively. There's a strong tendency to overdiagnose schizophrenia among African American men, especially paranoid schizophrenia, noting that, and also that now formally this idea that there's more violent than other mentally ill individuals. We had a multi-million-dollar grant because we were trying to look at some of the causes of this and found that we tried a whole bunch of ways using biographies, independent evaluators and others, and this still continued. And then recently, when we tried to resubmit to do some further studies, of course, we got the report from NIH that this has already been studied enough. So this is there's an ongoing issue around this, and then there's one other theme that's popping up in a number of fields. That is that I've had. I'm thankful to the federal government. I was in part of getting several multi-million-dollar grants trying to find the genetics of depression and the genetics of bipolar disorder and schizophrenia. And the genetics of depression with several big grants that simply couldn't find a punitive gene.
We had enough of y'all Black people. We had enough of y'all Black people.
That's right. And the idea and the issue is maybe there's not a punitive gene. Maybe environmental factors are going on. And we begin to recognize this finally, the same thing with Alzheimer's. The focus has been on finding a gene for Alzheimer's, when in fact we're now finding that lifestyle, social issues, and so forth may be just as important, even in these disorders that have what we've identified as at least a punitive biological basis. So I want
Do you have any questions for the speaker?
No, Bill is hitting on a number of important points, but the whole notion of the genetics of these disorders, which have gotten a lot of attention. Certainly, there's no one gene that drives things. It seems to be a network of vulnerabilities that genetic vulnerabilities, but clearly the social environment is playing a significant role, at least in terms of the differences in outcomes that we're seeing between Black and other races and ethnicities in America.
Dr. Abrams, anything in the chat?
There's a question. I'm trying to right now see who this is. Oh, Dr. Gibson has a question.
Dr. Gibson? Can you unmute Dr. Gibson?
I really appreciate the opportunity.
He's unmuted.
Can you hear me?
Go ahead.
Barely.
Could you get a little closer?
Just 1 second. Is that better?
Yes.
Yes.
Much.
Okay. I just wanted to thank you, Dr. McLeod Bryant, for your excellent and prescient presentation. It's so very timely. And in addition to some of the things that I mentioned in my personal communication with you, I wanted to ask you, what say you about food as medicine as it relates to mental health in the community? Such a very powerful, powerful, powerful tool we have in our toolbox that I don't think gets mentioned often enough. What say you, good doctor?
Excellent question. I appreciate that question, Dr. Gibson. When you look at social determinants, I mean, I think one of the fascinating or unfortunate social determinants is the fact that many of these very vulnerable zip codes are food deserts.
Yes.
They're places where it's difficult to get any, organic or, healthy, fresh nutrition. It's much easier to get the ultra processed fast foods or liquor stores and that sort of thing. And that is sort of in a macro sort of way goes directly to your question, Dr. Gibson. Um, the notion of food being medicine has been, I think, um, relatively lost when it comes to um, psychiatric care, although we're, more and more attention and focus is being placed on it, whether we're talking about just the impact of gluten-free diet. I've seen that personally with a particular patient that I was treating in a mental health center who was on a number of different medications for anxiety and depression and mood swings, and then was discovered to have celiac disease, went on a gluten-free diet, and she's on half the medications that she was on previously. Much more attention being placed on the gut biomes. We had a poster presentation at our transcultural conference, Black psychiatrists that I mentioned earlier, where I gave this talk in which the presenter talked about pro and prebiotics, things that I'm frankly, I don't know much about, but he was talking about the impact that some of the testing that could be done and changes in terms of diet and the impact that it might have on mental health was very exciting. And so it's a long way of responding to your question, but clearly, we prescribe a diabetic diet for folks with diabetes. We're understanding more about the impact of processed foods in terms of just poor health in general and the impact that it may have on mental health. And I think, this is the sort of thing that could be, in a sense, revolutionary. But again, when it comes to our communities, we have to find ways to increase the access, not only in terms of having places where folks can go or to grow their food, but to be able to afford these various foods that are healthier for them.
Dr.
Dr.
Maxey, could I ask one
Go
uh,
ahead.
question before we end? I want to take advantage of the fact that we have all of this talent today, and we're 2 weeks away from the beginning of the season. I was wondering, Dr. McLeod Bryant, if you had any recommendations or ideas that you would be willing to share with our audience as to how they can maximize the good things that can come out of family gatherings and what can be done to protect yourself if you find yourself isolated during these holiday times.
This is a great question, and in fact, it's a whole nother subject area that many of us are could talk for quite a while about. I'm going to just frame it very succinctly in terms of maintaining one's social rhythms. And there's a whole there's a therapy, a social rhythms therapy that's been developed to try to help folks with mental health issues regain control of their lives without medication. And the whole notion behind social rhythms is that there's important biological functions that if we can routinize them and have healthy habits around them, we can help maintain our joy in much better ways. And so, for instance, our sleep-wake cycles. One of the things that interferes with our ability to truly enjoy the holidays is the fact that we start going out to parties and we start, hanging out and doing all sorts of things and running our batteries down, and we're not paying attention to that we need a certain amount of sleep in order to, to function at our best. And so maintaining the social rhythm of our sleep wake cycle, it doesn't have to be every night you have to be in bed by 11, so to speak, but as much as possible, you're maintaining relatively within an hour the same sort of bedtime and the amount of sleep that you're getting in the bed. That's an important function. The fact of how we're eating, healthy, trying to maintain as healthy a diet as we can, maintaining sort of the ritual of when we're having our meals. If you typically like to have breakfast in the morning, you're not sort of skipping that or waiting till late just because of, the holiday sort of thing. You try to maintain that rhythm to help to feed your body, your brain, and your spirit. Your spiritual rhythms, maintaining, whether it's prayer, meditation, your visits to your house of worship or whatever, maintaining those sorts of patterns, patterns of grounding oneself, having time for just spending time personally alone, whether that's during your prayer time or whether that's just reading a good book or whatever, maintaining those sorts of rhythms. Those are the sorts of things that can help maintain one's health and joy during even the most difficult times. Because as you all know, the holidays can be stressful, not only because of interactions with the family, but the lack of interactions with folks that have passed that you may be missing because they're not with you. But trying to maintain one's healthy rhythms is one of the best ways to deal with the stress of the holidays.
Thank you so much for an excellent answer. Before we go to our final comments, I would like to just address one more issue. You had a slide where you showed the increased psychiatric problems of multiracial people. Could you just discuss that for 1 minute before we go to the final comments?
So, I mean, I think there's a number of theories about that. Just in talking to individuals who see themselves as multiracial, oftentimes there's a sense of ostracism, of not being truly a part of any particular race, or being identified as the other, even though they may want to be a part. They may appear to be Black, but as soon as they identify that a very important part of their identity is of a different race, they're then kind of pushed away or seen as being different. And I think that stress of not feeling a part of a larger group that they aspire to it can be damaging to one's mental health. That would be sort of where I come from it. But there are a number of theories about sort of the social stresses that they may be experiencing in America.
We thank you so much. We'd love to have you back at some point to address us again. We'd like to have final comments for today.
Final comments from me?
Yes, sir.
Oh, well, it's been a pleasure to be able to present to you these ideas, and I just hope that that they stimulate each of us to be champions of this notion that this is an issue that's not going away. It's a reality, and that we all need to play a role in trying to address and remove these disparities, and be out there looking for allies who may not realize that they can be and should be allies.
Well, thank you so much again. This is an excellent talk. Dr. Lawson, final comments?
Yeah, 3 points. One is we did some work showing that if you tyrosine deprivation in normal people, they get depressed. Not an issue in terms of most Americans because we have great diets, but for those of us in food deserts, alcohol use, and others, you do run the risk of being malnourished in those kinds of basic elements that are necessary to prevent depression. Second point is that it's important to recognize that one population we still need to do more of this. There's a talk on this. We need to do more of looking at mental health in our primary care centers, identifying them, mental health in our correctional systems, and mental health in our substance abuse systems. For whatever reason, these groups are overlooked, understudied, underevaluated, and addressed in terms of most of the research projects.
Thank you so much. Dr. Barbara Neighbor-Stevens?
Thank you. As we wind down, we absolutely will want to follow up on some of the many great ideas and thoughts that you gave us. If there was one thing that I kind of took away as a reminder is this is a we problem. It's not a you or an I problem. And the more we can get that across, that the problem is a we problem. I'm going to incorporate that in some of the things I do for sure.
Thank you so much. And again, Dr. McLeod Bryant, we thank you so much for being with us today. And we're glad to meet you, and you're very intellectual and your words are very clear. Everybody will be back next week, and we have a talk on gastroenterology problems, including liver and problems with the colon. Thank you very much. Have a great day, and thank you, Simon, so much.
Thank you.
Bye.
Bye.